All right, well, welcome everyone to our first On the Pulse gathering that is virtual. We're very happy to have you here. I am Chris Fortman and I am the CEO of the Minneapolis Heart Institute Foundation. And our vision here is a world without heart and vascular disease. And before we get into the very interesting presentation by Dr. Stephen Bradley, I would like to provide you with just a little background on the Minneapolis Heart Institute Foundation because it's one of my favorite topics. So first of all, we are an independent, separate nonprofit research and education organization. We have just over 80 staff that are entirely dedicated to the mission around cardiovascular research and education. We could do none of this work if it were not for our partners at the Minneapolis Heart Institute, where we partner with just around 80 cardiologists and surgeons who are asking very important questions that help improve care. And we're fortunate that these physicians are at the flagship hospital of Abbott Northwestern and are within the Allina Health System, the largest health system within Minnesota. This enables us to do very critical research. And if you look at the visual, it is through this research and through the education that we are able to improve clinical practice and provide our patients with more and more options. So there are two parts of our mission, as I mentioned, research and education. And if you take a peek at these pictures, it just shows you how excited we are about research and that we have over 200 studies happening. About half of those are industry-sponsored clinical research, and the other half are physician-directed research projects, which are core to our mission. We impact over 2,000 patients via this research. On the right-hand side, you can see a lovely picture of our interns, and core to our mission is preparing the next generation of researchers and healthcare practitioners. So we have almost 200 Minneapolis Heart Institute Foundation intern alumni who are out there doing important research and come here every summer to partner with a research physician to move our physician-initiated research forward. We're committed to providing professional and community and student and patient education, and all of this results in over 200 manuscripts being published in peer-reviewed journals. So here are just some fun pictures. If we really get down to it, it's all about the patients. You will see some of our very happy families that have been part of our research and are now advocates for what we do at the Minneapolis Heart Institute Foundation. We also often get the great fortune, because of our expert physicians, to participate in first in the world and first in human research, very critical. And again, getting out into the community. Some of these pictures show our Hope Health and Humor event focusing on women's cardiovascular health, our interns going out on field trips around the Twin Cities, we are Medical Alley, and our physicians providing research to our education to many of our community members. So the good news is I will be closing this up right now, mainly with a big thank you, because we cannot do this research without the community support, and most of this research is made possible by our very generous donors, our research and education. So we are grateful. Thank you. If you are interested in what's happening at the Minneapolis Heart Institute Foundation and would like to learn a bit more, please go to our website. You can see the link here, and we have a special COVID-19 page right now where you can hear or read the perspective of some of our physicians and what's currently going on. And we also highlighted some recent press release around this work, again, which Dr. Bradley will speak to. And as you may know, our staff, many of them are practitioners also and are ready to serve on the front line through emergency clinical research and just be called to serve patients during this time. So you can see a nice picture of our Tiger team there. With that, I'd like to ask Dr. Scott Sharkey, who is Chief Medical Officer and President at the Minneapolis Heart Institute Foundation, to introduce our speaker today, Dr. Stephen Bradley. Scott?
Oh, hello, everyone, and I hope each of you are doing well and are okay. And thank you for joining us today. And apologize for my apologize for my hair because you all know what that's all about. So my privilege, though, this afternoon is to introduce to you my partner, Steve Bradley. Steve is a general cardiologist with Minneapolis Heart Institute, a native of White Bear Lake. Graduated from the University of Washington, and where he received his cardiovascular training. Steve also has a great interest in public health and has a master's degree in public health, and he's our go-to person for public health issues, and there's no better example of that right now than the COVID epidemic. I might also tell you that Steve is on the editorial board of the Journal of the American Medical Association family of journals, and he can tell you certainly far before any of the rest of us what is the latest going on in this research world. So Steve, please join me up here, and thank you very much for taking the time.
So being appropriate for COVID, I'll join you up here after you leave. It's my pleasure to be here this afternoon, and really my objective is to just give some general thoughts about where we stand in terms of understanding COVID, and particularly COVID and cardiovascular disease. Be relatively brief to open for questions, and certainly try and provide you information and responding to your questions. So thanks for being here with me this afternoon. So again, COVID and cardiovascular disease. So I think it's helpful to first start with what is COVID. You wouldn't think that this is important unless you're living under a rock, but I think that there's a lot of misinformation out there, so it's important to address and provide a starting point for what COVID is. So COVID refers specifically to the disease caused by a virus, and the virus is the severe acute respiratory syndrome coronavirus 2. The reason it's 2 is because you may remember the SARS outbreak that was particularly relevant in the Toronto area as it began to spread, but then was suppressed there. That was the first SARS virus. So this is our second coronavirus that causes severe respiratory syndrome. This was a virus that emerged in Wuhan, China in late 2019. Its identification in 2019 is why we call it COVID-19. Common symptoms include fever, cough, and shortness of breath. That's really where we had focused initially. Now we're seeing that there are other symptoms you can have: sore throat, what we call myalgias, which is just muscle aches, fatigue, nausea, diarrhea. An interesting one, loss of sense of smell, appears to be not common, but a symptom associated. So this range of symptoms is typically a viral type syndrome. Most commonly is a mild illness, but it can progress to a very severe illness. Importantly, there's no known effective therapy. I want to make it clear, there's no known effective therapy. We're working very hard to try and understand if there are effective therapies, but at this time there are not. There have been more than 2.5 million total cases. I think these slides I created late last week. At that time, there were 177,000 deaths. I had looked this morning, I believe we're over 200,000 deaths. And again, in combating misinformation, I went to the World Health Organization, and I thought this spoke to me about just how much misinformation out there. This is the first thing you'll see on the World Health Organization of their slides. It says 5G mobile networks do not spread COVID-19. Now, if there's concern that you can get a viral infection by speaking on your phone over a 5G network, obviously there are a lot of misperceptions that we need to address. I won't even speak to one that came from the highest levels of our government last week. But again, don't drink disinfectants. As it relates to COVID-19 and cardiovascular disease, why is this relevant? Why is this respiratory flu-like illness? Why do we care about cardiovascular disease? So it turns out that this virus invades the cell, the pulmonary cell, the lung cells, through what's called ACE2. ACE2 is an enzyme that's involved in regulation of other enzymes that impact blood pressure. And so there are hypotheses that amongst patients who have hypertension or are treated for hypertension, there may be regulation differences in terms of this enzyme and levels of this enzyme that may then impact the likelihood of severe illness in patients who have these conditions. So we've seen in studies of the populations who have suffered from COVID in China and in Europe that severe COVID illness is more common in patients who have pre-existing conditions, most notably high blood pressure or hypertension, diabetes, and coronary artery disease. At this time, the reasoning for that are all hypotheses. We haven't confirmed why that would be, but part of this may relate to this receptor that's prevalent in patients with high blood pressure. So what are the cardiovascular manifestations of COVID? So I've spoken to you about this viral illness and then risk of severe illness that's predominantly a pulmonary illness. But we are also seen lung illness. We've also seen that cardiovascular manifestations of COVID as we've seen more cases across the world. So acute cardiac injury, this is defined by looking for enzymes that are released into the bloodstream when the heart is injured. We've seen in studies of COVID that between 7 and 22% of hospitalized patients with COVID have this acute cardiac injury. This is associated with increased risk of severe illness and mortality. It's not entirely clear, so there's a number of different reasons why this could happen. For some patients, because of the pulmonary process, they can become what's called hypoxic, so very low oxygen levels in the blood. That is a stress on the heart. As a result of that, the heart can release this enzyme. So it's not particularly invasion or infection of the heart as much as the heart is unhappy about the condition that it's working in at the time. That said, there is also, in rare circumstances, evidence that the heart itself can be infected. So this can cause what's called myocardial depression or myocarditis. In that setting, we also see a release of this enzyme, this evidence of acute cardiac injury, but we also see decreased heart function. And this can either be from the direct toxicity of the virus or infection of the virus in the heart, or the severe illness state. So patients who are very, very severely ill, thank you, Scott. I was looking to a general audience for the 3 people who are here helping us make this process possible, but not recognizing that my camera is back there. So hello, everybody. For this illness, it's possible also that because the patient is so severely ill, that can have an impact on the heart and cause what's called myocardial depression, where the heart does not squeeze as well. Arrhythmia, so that's an abnormal heart rhythm. We're seeing that in patients who have COVID, approximately 1 in 5 can have an arrhythmia. Our understanding of what those rhythm disorders aren't well understood at this time. It's just to say that 1 in 5 patients can have a rhythm disorder. And amongst patients who are in the ICU, we find this is more prevalent. The other reason rhythm disorders are important are some of the early treatments that were hypothesized, namely hydroxychloroquine or Plaquenil and chloroquine, which are 2 old immunosuppressive medications or immunomodulating medications that were used for rheumatoid arthritis and for malaria, were kicked around as possible therapies. Those medications have impacts on heart rhythm and increased risk of adverse rhythm disorders. So we have this balance of a therapy without proven benefit and a risk of increasing rhythm abnormalities. And published in my journal, the JAMA Network Open, just this Friday, was a publication looking at chloroquine and finding that, in fact, there was a higher risk of mortality in patients treated with high-dose chloroquine. So again, no effective therapies, and therapies that have been postulated to date do have potential risk. Finally, thrombosis. So thrombosis is the formation of clot in blood vessels, particularly in the venous blood vessels. So these are the blood vessels in the legs that return blood to the heart. We depend on our legs to kind of serve as a pump or almost a heart in the legs to push blood back towards the heart. And we find that in patients who are infected with COVID, there's an increased risk of blood clots in those blood vessels. It's thought in part that's due to the increased immobility of COVID. So patients who are sick with this illness, immobile at home, increased risk of clot forming. The infection is also an acute inflammatory state, meaning that the body is essentially under an inflammatory state, which also can cause clot to form. And there's a thought that the infection itself can cause damage to the blood vessels, which increases the risk of clot forming. So we're learning a lot about how to both prevent and manage that condition should it occur. There's also a lot that's come out in terms of the indirect impacts of COVID. So Santiago Garcia, who's my colleague at Minneapolis Heart Institute, Minneapolis Heart Institute Foundation, is an interventional cardiologist and is leading work of Stemi. So this is a common type of myocardial infarction or heart attack. He's leading work looking at impacts of COVID on Stemi care. So he's leading a registry through the Minneapolis Heart Institute Foundation, and he's also recently published on Stemi activations in the era of COVID. So a Stemi activation is when someone calls 911 because of a heart attack. And what he and his colleagues have found is there's been a tremendous drop in the rate of Stemi activations since the COVID pandemic began. And this includes areas of the country where COVID is not currently very prevalent. the concern was, and this is starting to bear out in our practice here and elsewhere, is that patients are not calling 911 for their acute heart attacks. And as a result, patients are suffering from these events at home and putting themselves at increased risk. We're also seeing, in a way that we've not seen in decades, complications from heart attacks from patients who are presenting late. In the past 2 to 3 decades, we've developed therapies that can treat heart attacks effectively to reduce the risk of long-term consequences of a heart attack. Because people are not presenting at a time that we can affect the impact of that heart attack, they're presenting with these long-term consequences, such as essentially what we call rupture or breakage of parts of the heart so that it no longer works in the same way, or holes in the heart because the heart muscle itself is damaged to a point that a hole forms. These are complications we haven't seen in decades. Now we're seeing them commonly because of the late complications of patients not presenting for their heart attacks. So it's important to remember that emergencies are still emergencies. We're here to provide you the care that you need. We're here to keep you safe. I'll then move on to work that we're doing with the American Heart Association. So I and colleagues who work in areas of quality improvement and quality assessment have been collaborating for the past 2 years, sharing our knowledge about how to provide the best care for patients to achieve effective, efficient, and optimal outcomes for patients with cardiovascular disease. So this map on the left shows the, I believe it's 16 centers that we're up to now that have been working collaboratively for the past 2 years to share our knowledge about how we're approaching management for cardiovascular conditions. As COVID began to arise, we began to have conversations about what are you doing in the management of patients with COVID as it relates to cardiovascular disease. And these conversations led to an understanding that there's an opportunity for this group to lead in obtaining data to understand aspects of COVID as it relates to cardiovascular disease. So in partnership with the American Heart Association, this group combined with what's called Get With the Guidelines, a 1,000 hospital registry to capture data on quality and outcomes of care for cardiovascular disease, is now being leveraged to harness data on patients with COVID. And as John Warner said, having sufficient data is the first step to understanding the impact of COVID-19 on cardiovascular health. In the span of less than a month, something that would normally take years, we've established this registry, the participating centers, the data necessary to inform ourselves about patients with COVID and their cardiovascular outcomes. We're moving forward very quickly and very encouraged by the collaborative nature of that effort. So one of the common questions I hear is, how do I keep myself safe? And given that we know there's no known effective therapy for COVID-19 at this point, it's about common sense measures to reduce your risk of infection with a respiratory disease. So first, hand washing technique with soap and water. So if you've not watched a hand washing video, if you're not familiar, I think it's helpful. The CDC has this nice little picture of what you should do when you're washing your hands. It's not about dipping your hands underneath the water and being on your way. It's about being thoughtful about when you turn the water on, when you get the soap in your hands, how you apply it, how you rinse, and then how you turn it off to maintain good hand hygiene. Masks have been something that are now becoming a part of our culture. So understanding how to use a mask is important. A mask is not helpful if you're putting it on incorrectly, or if you're not practicing good hand hygiene in the process of what we call donning and doffing, or putting on and taking off your mask. If you do that in a way that either contaminates your face as a result of the way that you've put on the mask, or contaminates your hands and then fail to adequately produce hand hygiene afterwards, you're not providing yourself the benefit of that mask. I think this one is from Journal of American Medical Association. There's also links in the New York Times that you can look at about how to put on and take off a mask. Maintaining social distancing. I've heard some talk about we're going to move away from social distancing to physical distancing. The idea that we still want to be social and we need to find ways to maintain that, but we need to maintain physical distance to reduce the risk of transmission. This is felt to be largely a respiratory droplet transmitted disease, meaning that the virus hangs on to droplets that are then transmitted and land on surfaces that someone else then touches and then puts in their eyes or their mouth, or that are, if you're too close, can be inhaled. So that 6 feet is intended to provide you that distance. There are other ways that the virus likely can be spread. but the 6 feet is intended for the respiratory component. And then finally, to remember that emergencies are still emergencies. So if you have symptoms that are new or concerning, or you have typical symptoms of a heart attack or stroke that include chest pain, chest pressure, shortness of breath, nausea, diaphoresis, meaning sweating, lightheadedness, or have symptoms associated with a stroke, sudden loss of strength or feeling on one side of your body, as drooping face, inability to either understand or communicate, produce words. All of those things are immediate concerns and warrant a call to 911. So I'll summarize at this point, and I'm really excited to be here to have the opportunity to take your questions. COVID-19 clearly has disrupted all aspects of life. It has disrupted healthcare in particular as we try and work with our patients to help keep them safe, but at the same time making them understand that we're still here in the case of emergency. There's an evolving understanding of the interplay of COVID-19 and cardiovascular disease. I spoke about how COVID uses a receptor involved in hypertension. We are still at the very beginnings of understanding what that means in terms of treating people with cardiovascular disease to reduce the risk of adverse outcomes from this infection. But through things like the HIA registry and the work of Dr. Garcia and his Stemi registry, we will begin to understand those issues. And as a result of that type of work, MHIF is poised to be a significant contributor to understanding COVID-19 and cardiovascular disease. And with that, I'll close, but I'm really excited for the opportunity to take your questions.
Alrighty, so it looks like we have a couple questions into the Q&A pod. Just a reminder, please enter your question in the Q&A pod. To access that, you will need to drag your cursor to the bottom of your screen. A control bar will pop up and click on the Q&A pod, and please enter those questions. I see that we've got quite a few flooding in, so we can start right now. So, Dr. Bradley, first of all, thank you for presenting. Is there any correlation with being on blood thinners and cardiac events with COVID-19?
Yeah, that's an excellent question. As of yet, we have no data to suggest there's a correlation between being on blood thinners and either being infected with COVID-19 or having adverse events. That said, most people who are on blood thinners have risk factors such as atrial fibrillation or other cardiovascular conditions such that those patients are likely at higher risk, but it's not related to the blood thinner per se as it is a marker of those conditions that they carry.
Thank you. Another question here. Is there evidence that some people with cardiovascular diseases who contract COVID-19 suffer minimal symptoms?
So a great question. The vast majority of patients who suffer from COVID-19 or SARS-CoV-2 infection will have minimal symptoms. That said, a significant proportion of patients will have serious illness. And when I say significant, when I give you a percentage, you're going to say that's nothing. When we talk about the percentages of population, we end up with things like overrunning New York City because we're unable to provide the healthcare that's needed. So patients with cardiovascular disease is more likely they'll have a low burden or minimal risk infection, but the likelihood of a serious infection relative to someone who does not have those conditions is markedly higher, on the order of 5 to 10 times higher.
Thank you. So how does COVID-19 impact those with coronary artery disease specifically?
So the impacts are not any different than they are for patients who do not have those conditions. The concern is that patients who have those conditions are at a higher risk of a more severe illness. So even amongst patients who have no risk factors, we see that some patients will have a very severe illness. So a 40-year-old, previously healthy, no comorbid conditions, meaning they don't have heart hypertension, they don't have coronary disease, can still have a very severe illness, meaning that they end up in the ICU and end up intubated for a very long period of time. Patients who have cardiovascular disease, the disease isn't different. They're just at a higher risk of that event happening.
Great, thank you. Just a reminder to attendees to please enter your question in the Q&A pod. I see quite a few people are raising their hand, but go ahead and click on the Q&A pod and type your question in, please. We would really appreciate that. We've got a few more questions coming in here. Do you have any comments on blood pressure medications?
Blood pressure medications are good in the sense that we still believe that we should control hypertension for patients who have that condition. There, again, this hypothesis around this enzyme and specific blood pressure medications that have implications on that enzyme are what's called angiotensin converting enzyme inhibitors, or ACEs, a common one being lisinopril, or angiotensin receptor blockers, or ARBs, a common one being losartan or valsartan. When it comes to things that we don't know about, we tend to follow the dictum of first do no harm. And because there's potential harm for taking those medications away, and we don't know the benefit versus harm of taking them away in the setting of COVID, our current recommendations are for patients to stay on their medications. It may come that we learn that, in fact, those medications are beneficial. It may come that we learn that those medications increase risk. But for now, the risk-benefit balance are such that we recommend patients maintain their medications because we know that has implications for heart health. And we'll learn more in the very near future about what that means for COVID health.
Excellent. So can you speak to the aerosoling of the COVID virus and whether 6 feet is adequate?
Yeah, so aerosolizing, I mentioned that it's not just about droplets. The sense is that the aerosolization, what that means is that instead of it being attached to a droplet, it's essentially almost a particle in and of itself. Things like the little surgical mask that I was wearing do not protect against aerosolized particles. The feeling is that in general transmission, the risk of that is relatively low. Where we worry about that more is in the healthcare settings with patients who are in the ICU, who are on ventilators, which is an aerosolizing process, so there's more of those types of viral particles. That is a component of how this is believed to be transmitted, but is felt to be lesser.
Thank you. So what are the chances for a person staying at home after having cabbage? What are the chances that they will get COVID-19?
Same chances for all of us. So again, it's a viral infection. We're all at risk because none of us has been exposed to this virus before. The differences are how your body responds to it. And what we're finding is that patients who have pre-existing conditions, prior bypass would speak to someone who has coronary artery disease. Those patients are at risk of a higher, more complicated infection if it should occur.
Thank you. So this one's a little more specific, but is there any of my normal meds like Met, Lissy, or Spiralac, should I stop them if I get the virus?
So you should do nothing without the discussion with your provider. So what this comes down to is a lot of this is unknown and becomes a discussion with you and your provider about what are the risks and benefits of certain therapies as it relates to maintaining your chronic medical conditions and your acute medical condition. Our current recommendations are largely to continue all of your medications, and you should always have a conversation with your provider before you make any changes to your medications or any decisions about stopping any medications.
Thank you. So does having hypertension put me at a greater risk of morbidity and mortality with COVID-19?
It does. So, and again, not understood why, but we're finding that patients who suffer a severe illness with COVID are more likely to have underlying conditions, including hypertension.
So a follow-up, is this true even if the hypertension is controlled by medication?
It's the question my dad just asked me yesterday. This is true even if your hypertension is controlled. So once you have a medical condition, just regardless of the degree of control, that condition carries with you. So that is a marker of your risk going forward. So amongst patients who suffer from severe COVID illness, that's all patients with hypertension. What's not been studied is whether or not even amongst patients with hypertension, that those who have poor control relative to good control, but hypertension is a risk factor for worse COVID infection or worse outcomes with COVID.
So do you have any comments on the recent reports of younger people in their 30s or 40s with mild COVID symptoms experiencing strokes?
Yeah, I can thank my wife for pointing that out to me this weekend. I was unaware of that. I think it comes back to this concern about increased risk of clots forming in the setting of this infection. And again, something that's incompletely understood at this time. There's a lot of work going on about what's the appropriate management strategy to reduce the risks of these types of complications. And one of the challenges is as we have more patients infected with this disease, more patients experience the full spectrum, we start to see some of these other things that are uncommon but important for us to understand. I would put this in one of those uncommon but important for us to understand, and we're learning more.
So with a 17% higher risk of arrhythmia, is there anything you are doing to more closely monitor these patients?
Yeah, so important to recognize that it's not a 17% higher risk of arrhythmia. 17% of patients who were hospitalized had arrhythmia. For all we know, if we took a look at all patients in the hospital, we would say that 17% of patients in the hospital have an arrhythmia. So again, it's just something we need to be aware of and learn more about at this point. It's not to say that there's something different, particularly about COVID. That said, we are monitoring patients closely depending on what else is happening. So patients who have cardiovascular conditions or a complication of their cardiovascular condition in the setting of COVID, we would monitor them in the same way we would for patients who are in the hospital for a heart attack or heart failure. We're not specifically monitoring for rhythm disorders in low-risk COVID patients because the risk is felt to be low.
Thank you. So we've got quite a few more questions coming in. And just a reminder to attendees, please enter your questions into the Q&A pod at the bottom of your screen. We really appreciate that. So another question is, are you differentiating, are you keeping track of data between the damage suffered from the virus to your heart versus lack of oxygen?
Yeah, that's an excellent question. And one of the challenges is clinically, at times we can't tell the difference. So a patient who suffers from a severe COVID illness and ends up intubated because of hypoxia, low oxygen saturations, if they have injury to the heart causing release of this enzyme, at times we can't know for certain. In those settings, more often than not, we will take a picture of the heart, what's called an ultrasound, that gives us information about the heart squeeze and heart function. That data will be captured by the AHA registry that I mentioned. I sit on the steering committee for that registry, so we've built out the data elements to try and understand that aspect as best as we can. But at the end, there will be some gray in there because we can't say with perfection.
Thank you. So how does COVID-19 affect generally healthy individuals, but who also have an arrhythmia? As an example, this individual is 44 and is active, but also has ARVC.
Okay. So when we say impact, and I want to make this really clear, the virus impacts people in general the same. There's some variation in terms of some people get more sick than others. There's some variation in terms of some people have other organs affected more than others. So we spoke about heart. There's some evidence of neurologic conditions in rare circumstances. But what drives that is an unknown at this point. So for a 44-year-old person who is healthy aside from the RVC, I would say that the virus would affect you in the same way as it affects all of us. More likely than not, if you have an infection, it will be mild. There is a risk that you'll have a severe course that would include hypoxia, low oxygen, and potentially need for supportive care beyond being able to be cared for at home. But the degree to which I can say that risk applies to that person isn't known.
Thank you for that. So could you just expand on what an underlying condition would be? Specifically, an example would be, so the elderly and those with underlying conditions need to be especially cautious. So could you just expand on what underlying conditions?
Absolutely. So when we say underlying condition, we generally mean that something that you weren't born with. So as we get older, we generally accumulate conditions, and they become underlying in the sense that when you're exposed to something like COVID, you've now got another thing, but you've got these underlying things that you've accumulated over time. So oftentimes as people get older, they may experience a heart attack. That would be coronary artery disease. They may find that they've got elevated blood pressure over time. That would be high blood pressure. Those would be the underlying conditions that you carry forward with you as you continue to get older. And then when you are at risk of COVID, we talk about, are you a person who has these things that you've accumulated over time, or are you someone who's not? So some folks are very lucky and they make it into older life without these additional conditions they've accumulated, so they have no underlying conditions to be aware of. Really, their only underlying condition is the years that they accumulate. We've seen that patients who are older are at higher risk of severe COVID infection. So when we talk about underlying conditions, we're talking about additional medical conditions that you have irrespective of COVID.
Thank you. So this person writes, if I understand correctly, blood clotting is a factor for some patients. Are there steps being taken to increase aspirin and or Plavix use for the prevention of STEMI?
Let me try and clarify a couple things. One, for patients who are hospitalized with COVID infection, we know that blood clotting is a concern, and so patients who are hospitalized, we're working hard to understand the right, essentially anticoagulant, blood thinner approach to management. For patients who are outpatient, the vast majority will suffer a mild illness with this condition. So the use of things like aspirin and Plavix have risk. The risk is bleeding. So if we were to give more aspirin and Plavix to people in general, we would increase the rate of bleeding events in our population and potentially dwarf any benefit from that in terms of reducing events. So we're not encouraging increased use of therapies. To do that at this time would be in the same way to say that we think that chloroquine is effective, when in fact we don't know that. So first, do no harm. There would be potential harm to advising additional therapies at this time, so we're not advising additional blood thinner therapies.
Thank you. Let's see. So is there danger any more than a flu to patients with cardiovascular disease?
Yes. The flu, when we look at the mortality rates, are not the same as they are with COVID. Unfortunately, our understanding of the mortality rate for COVID is all over the board because we have an insufficient understanding of how many patients have actually been infected to inform us about how many patients have suffered from the infection in a severe way. But looking at population trends of what happens with influenza on a yearly basis, this is significantly more severe than influenza.
Thanks. So is someone without cardiovascular history at risk of cardiovascular complications with a COVID infection?
That's a great question, and I'll frame that in the context of infections in general. We know that patients who suffer, for example, a respiratory illness from influenza or pneumonia are at higher risk of cardiovascular complications around the time of that event. And patients who have underlying, again, that word underlying conditions like cardiovascular disease are at higher risk of those events than patients that don't. In the same way, with COVID, it is a stress on the body that increases the risk of things like cardiovascular complications, particularly amongst patients who have cardiovascular disease. And the challenge is when I say that, I'm talking very small differences in risk, but to be honest, there is an increased risk.
Great, thank you. So since many heart-related meds are produced overseas, should we be concerned with availability?
You know, I won't touch that one. Not because I'm concerned, but because I think anything I say has potential to be wrong. So, you know, I'm surprised that nobody's actually asked about the models as of yet. I was anticipating that to be a question. I'll put this along the same lines. The models that have been developed to help us understand the trajectory of this disease have been wrong, but they've been useful. They're wrong in the sense that everything's changing so fast that we really can't predict beyond about 2 weeks what the world's going to look like. So to say what supplies and availability of medications is going to look like beyond 2 weeks would be irresponsible for me to do. My hope is that things continue to move forward in a positive direction, and those won't be issues, but I honestly don't know.
Thank you for that. So are emergency responders changing their approach to people who are having a cardiac arrest during this pandemic?
Yes. So given the concerns about COVID, management of cardiac arrest includes chest compressions and intubation and airway management, which is an aerosolizing procedure. So it generates these particles that are of increased concern about transmissibility. So there have been guidance from the American Heart Association in terms of modification to CPR. One of the first steps in management of patients who have cardiac arrest is to survey the scene. Added to that is the safety as it relates to, do you have adequate PPR, personal protective equipment, PPE, personal protective equipment to perform CPR for this patient. So first responders are adjusting to make sure that they are safe as they provide care to others.
Thank you. So when do you expect antibody testing to begin?
It has begun. There are concerns about just the accuracy of what those antibody tests mean and what they reflect in terms of recovery from the illness. This is one of those things that I hope we know more shortly, but I won't say much more beyond that.
So are patients with LVNC, do they have a higher risk?
Left ventricular non-compaction, maybe? Yeah. Excellent question. Left ventricular non-compaction is a condition where the heart does not essentially open up in the same way as it's intended to and is a little thicker. It's a relatively rare condition, and so there's not enough data to say specifically for patients with left ventricular non-compaction.
Thank you. So can you please just quickly re-explain how the virus attacks the ACE?
Sure. So it doesn't attack the ACE as much as it, let me see if I can go back to that slide. So ACE2 is an enzyme that sits on the membrane of tissues, including the lungs. And so ACE2 is in two forms, a soluble form that circulates in the bloodstream and one that's connected to the surface of the cell. The soluble form is the one that's felt to impact and degrade some of these enzymes that are involved, or these essentially hormones that are involved in blood pressure regulation and has an impact on lowering blood pressure. But it just so happens that that enzyme is the same receptor used by this virus. So the virus attaches to that enzyme, which then leads to it being pulled into the cell.
Thank you for that. Well, we've got a few more questions here. This next one is, I have non-obstructive hypertrophic cardiomyopathy. Only symptom is occasional AFib. Any COVID additional risk for me?
So great question. Not enough data on that specific disease condition to say. The atrial fibrillation is something that would likely be lumped into other patients with atrial fibrillation. And again, cardiovascular conditions in general, we're seeing higher risk, but not specific to that condition because we don't have enough data.
Okay. This one's a little different, but how important is using compression socks if one has heart failure with normal ejection fraction?
Important is an interesting way to phrase that. So compression socks in the setting of heart failure with preserved ejection fraction won't make you live longer, but it might help you feel better. And one of the concerns about edema or swelling in the legs is that if it's not well controlled, it can cause skin breakdown. So oftentimes we suggest that more for control of edema to reduce the risk of skin breakdown.
Thank you. This one's a little specific as well, but this attendee writes, I check my oxygen level each day. It has been consistently 94 to 96%. At what level should I seek help at an ER? This person says that they have conditions like AFib, stents, pacemaker, diabetes, and that they're 80 years old.
Yeah, so great question. I tend to avoid use of home pulse oximeters in guidance of clinical care because that number is only a number and we need to tie it into the totality of how they're doing. So I would pay less attention to that number, and for me to give a specific threshold would be irresponsible. It's more about that patient paying attention to other symptoms or concerns that make them think that they need to either contact their provider or be seen.
Thank you. We have a couple questions that are about lifestyle and if remaining physically active does anything in terms of prevention with COVID. In the same way that we have no known therapies, we have no known preventive measures other than good hand hygiene, social distancing, and to a degree masks. So the other components of exercise, lifestyle, stress reduction
are important for overall health. Is it possible that doing those things is also beneficial for COVID? Absolutely, but I can't say with any specificity that there's any specific things that you should be doing in lifestyle to reduce your COVID risk. To reduce your COVID infection risk, it's about cleaning your hands, social distancing, wearing a mask, call 911 if you have an emergency. But it's important, obviously, to take care of yourself. So we like heart-healthy diets, fruits, vegetables, whole grain, heart-healthy fats like avocados, olive oil, fish that's not fried. We like exercise, 15 to 30 minutes a day of moderate to vigorous activity, stress reduction. So all of those things are important, but I can't say that they're specific to COVID.
Thank you very much. So it looks like we have about 10 more questions. So as more people appear to be having heart attacks at home, instead of coming to ERs, is there any tracking on the numbers of those people that called 911 but were not brought into the ER?
That's a great question. The concerns is not so much, so when we say Stemi activations, that's more patients who never called EMS to begin with. So EMS is 911. The likelihood that a patient was seen by EMS and not brought in for a heart attack is small. So we're not specifically tracking that, but we will track and are working with partners based out of Emory, a national data registry looking at out-of-hospital cardiac arrest and trying to understand, have there been changes over time, and could that reflect changes in people presenting to the hospital, staying at home?
Thank you. So do you have any general thoughts on Minnesota's plans for testing and modeling versus other states?
General thoughts. So I've seen the plan for testing in the sense that they've expanded dramatically. They now have testing centers throughout the state. So we've gone from tests essentially only available for healthcare workers and those who are infected in the hospital to broader testing. That will be important, understanding the scope, the breadth and depth and scope of the disease in our state. So that's a good step. In terms of modeling, I'll say what I've said before. I think all models are wrong, but some are helpful. So, I think that we run the risk of people seeing what was projected to happen. We'll say that's not what actually happened, and then the conclusion will be, well, either we overreacted or this wasn't as big a problem as we thought it was going to be. I think that's an incorrect conclusion. The reason things look different is because we did different things to prevent this from being overwhelming like it was in Italy and New York City. We don't know what the future looks like because we don't have adequate testing as of yet to inform us about where we've been. And without that, we don't know really where we're going. So all I will say is that it's not unreasonable to say what the next 2 weeks might look like. But beyond that, I think it's anyone's guess because there's going to be changes over time about how we reopen society. There's going to be changes over time about how much we understand this disease has actually spread in our state and elsewhere. And time will tell. I think patience is a virtue here to help us get to that point that we can do this safely.
Great, thank you. So to be clear, are masks only to prevent spreading to others versus stopping inhalation?
That's another great question, and I have my own. I try not to go off script from what's generally recommended, but my concern is a lot of what's been said about masks was initially about it not preventing infection was mostly because we had inadequate supplies of masks for everyone to use one. It doesn't make a lot of sense to me that a mask is a one-way valve. So I would think that it probably does both. It's being promoted as reducing asymptomatic spread. So if we all wear one and it turns out that I have this disease, I actually have my mask sitting on the counter there and I took it off once everybody was more than 6 feet away from me. But if I have it from having been in the hospital last week and I'm asymptomatic, then I'm not shedding the droplets in the same way. So I think that's the primary reason it's interpreted as preventing spread from people to others, but I don't see why it's a one-way valve. If you're doing good hand hygiene, I think it's beneficial both ways.
Thank you very much. So is there a relationship between the virus and adipose tissue?
So adipose tissue is fat tissue. There is evidence that obesity is one of those underlying conditions that puts patients at higher risk for a severe COVID infection.
Thank you. So this attendee writes, I had a very large blood clot 1 year ago in my heart causing moderate HA. Would this put me at greater risk of recurring thrombosis?
So I'm looking at Scott for moderate HA, and we're both scratching our brains about what that might be. We don't have enough data to understand if patients who have underlying clotting disorders are at increased risk of clotting disorders with COVID. And that's about as much as I can say.
I think moderate heart attack, if from a layperson's.
And I think my answer would be the same. So if you had a heart attack, your risk of severe COVID infection is higher because it fits in that underlying conditions that we know about. We don't know for patients who have a history of a clotting disorder, like what's called a pulmonary embolus, which is a clot inside the lungs, or a DVT, which is a clot in the veins of the legs, whether or not you're at increased risk of either more severe COVID infection or clotting disorders.
All right, thank you. I know you brushed on this just a little bit, but a little bit more specific question is, what is the predicted percentage of the general public that will be infected? And what's the percentage of healthcare workers that will likely be infected?
Yeah, so it depends on, again, all models are wrong, some are helpful. So the current model that's being proposed by our former state epidemiologist, Osterholm, who's giving a lot of guidance to Governor Walz, is essentially that this will continue to spread through our population until we achieve a level that enough people are infected that it will slow down. So that's basically herd immunity point. And he's suggested that this will continue to spread through the summer until more than 60 to 70% of our population are infected. It will continue to spread essentially until all of us are infected. There's no virus, or excuse me, there's no vaccine to the virus, and there's no effective therapy to either prevent or treat it. So it's not unreasonable to think that that may be the case. The degree to which we practice social distancing, good hand hygiene, masks, slows the rate of that spread. So earlier this spring, it was projected that we would achieve that peak like late May, early June. As we've continued to do this good work, the state projections have pushed it out further and further and further because it's going to take longer for us to achieve that point where all of us are infected.
Thank you. So does AFib or coronary heart disease increase the chance of getting a more severe case of COVID-19?
Yes, it does. So coronary artery disease is one of those conditions that we found patients who have underlying coronary disease are at higher risk of more severe infections.
So this person believes that they might have had a mild case of COVID-19 in early March. Should people that think that they had it get tested?
So there's two types of tests. One is to be tested for active infection. So that's looking for the virus, essentially a swab in the nose that then captures the virus, and we look for it in what's called PCR. That would not make sense for this person. The other is to test for antibodies, serology, so blood tests looking for evidence that you've been infected. Without additional guidance in terms of how we're using that in our community and our society, I think it's premature to suggest that at this point. There will come a time where we're likely put large proportions of our population through that, predominantly healthcare workers, to understand who has been exposed or recovered and potentially, not known, but potentially immune to reinfection. And then as we open society, how that falls together will be guided by hopefully state and federal leadership.
So are newborns at risk or at a higher risk of getting COVID?
Everybody's at the same risk of getting COVID, and it relates to how well you practice hand hygiene, social distancing, masks in terms of when you get COVID. So the risk is the same. The risk is for a more serious illness with COVID infection. Newborns are not felt to be at increased risk of a serious illness.
Thank you. This attendee writes, I have cardiac sarcoidosis and I'm taking medicine for treatment. What is my risk?
Yeah, so cardiac sarcoidosis is an inflammatory condition. can at times be treated with medications that are immune modulating. And we don't, and I think it's important to, again, clarify the difference between risk of infection is the same for everyone, dependent on how well you wash your hands, social distancing, and masks. Risks of a serious infection are if you get infected. And we don't know enough to say specifically for cardiac sarcoidosis.
Thank you. So this attendee writes, if a patient is having cardiovascular problems and may be at high risk, should they worry about going to a medical facility right now?
So can you just say that for me again? I just want to make sure that because this is an important question.
Yeah, so this person was wondering if someone is someone who is already at high risk in one of those vulnerable populations and they're having cardiovascular symptoms, should they be worried about contracting COVID-19 in a medical facility? Yeah, so I think that's an excellent question that we need to dispel concerns about putting yourself at risk by contacting healthcare. But there's a spectrum of cardiovascular symptoms. There are sudden onset, acute, meaning happening suddenly, new symptoms that would be concerning for heart attack, stroke, or rhythm problems. And I briefly discussed those in terms of chest pain, chest pressure, shortness of breath, fainting, loss of weakness, loss of strength or sensation on one side of the body. Anything that's new and concerning like that is concern for an emergency, and you should not fear your risk of exposing yourself to healthcare, because the risk of not treating that emergency is magnitudes much, 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 much higher than is the risk of contracting COVID from healthcare facilities. We have worked to what we call a cohort or isolate patients who either have COVID or risk of COVID within our hospitals, within our emergency rooms, within our clinics, to make it so that you can see us in a safe way. At the same time, some patients who have cardiovascular disease have symptoms that come and go and have been essentially stable for years. And so if you have those symptoms, you say, oh, this is my new thing, but I'd like to touch base with my provider to just check in and see if there's any guidance. We have ways we can do that in a way that you don't need to expose yourself to us at all. Meaning we can speak to you on the phone. We can do video visits virtually. We've started that process within MHI just in the past month. So we can provide you the care that you need in a way that you don't need to come into healthcare. But I want to make sure we don't mix the message that if you have new and emergent symptoms, we are here for you. We'll keep you safe. Excellent, thank you. Just have 3 questions left, so we really appreciate your questions. And thank you, Dr. Bradley, for speaking on these questions. And this person writes, so although blood clots are common in patients who are immobilized, this can't possibly count for the number of those COVID patients who have developed clots. Are there any other possible reasons for the formation of these clots, such as an immune system response to the virus?
Yeah, so I may have kind of glossed over this. It's felt that COVID may produce an inflammatory response and or damage to the vessels that increase the risk of clots. So yes, many patients come into the hospital and are immobilized for a day or two or less mobile than they are usually, but we don't see clots in those patients to the same degree that we're seeing them in COVID patients. So they're right, there's something else going on. We've got hypotheses as what those might be, but we don't fully understand them yet.
Thank you. So this attendee writes that they had a heart transplant 2 years ago and they were working part-time. How long until they can go back to work relative to COVID-19? Should they be worried?
That should be a conversation you have with your provider.
Okay. Thank you. This attendee writes that they are 70 and in the 79th percentile for a CA-CT scan, but they have no heart disease except for a lot of plaque due to high lipoprotein A from his father. But he says he passes stress test echoes with flying colors. Could you explain any added risk that this person has had?
Good question, and it starts to get into nuances about how we classify diseases. This patient, by the definition, has what's called atherosclerosis, meaning cholesterol plaque in the blood vessels. In some settings, we would define that as coronary artery disease. There's plaque in the blood vessels, but oftentimes when we do epidemiologic studies, meaning looking at populations and risk factors associated with outcomes,
that patient wouldn't necessarily be classified in the group that has coronary disease. Usually that's patients who have had a prior heart attack, prior stent, or bypass surgery. So I would say something on the order of it's an underlying condition associated with other underlying conditions that put patients at higher risk of adverse outcomes with COVID, but we can't say specifically for that setting.
Just one last question here is, could you just talk about underlying conditions in terms of valve problems relative to COVID-19?
Yeah, good question. We have not seen specifically associations between valve conditions and outcomes of COVID-19. In part, that can be because we don't have enough experience yet. It's the patient populations that we're describing are several hundred becoming several thousand, but we have not seen an association between valve disease and COVID outcomes as of yet. Thank you.
Thank you.
All right, thanks everyone for joining us.
Thanks, Steve. Great job.
Wow.
Really good.
Thanks.
Fun.